VT is like our famous VT is Vivek Tandan. Yeah.
Thank you, Datta. So in the last 2.5 days, I'm sure all of you have seen complex cases, very complex cases, very, very complex cases. You have learned new techniques. But I think we should also learn something which is very simple at times. And we should relive our days of residency, and there are so many alumni which I see here. So I thought maybe we should relive our days of residency. So can I invite few of them, Harshit, Roshan, to come forwards and participate in the discussion? You can speak anything, we won't judge you, we are not going to fail you anyways now. Harshit, Roshan, Gopal, Hitesh, come near the mic.
Hitesh in the Rai bol rahe हैं. Hitesh Gurjar को नहीं बोल रहे भाई. आ जाओ.
Yeah, Hitesh is not here, so.
Yeah, Hitesh is not. So only one Hitesh.
Yeah. Hitesh is only one Hitesh here. In Hitesh Gurjar's language, this is a KBKL case. Anybody can do it. So it's कोई भी कर लेगा इस केस को. So, and why don't you, Gokul, you also come near the mic. Let us hear from the young people.
You tell me whom to ask. I'll go to him. Don't worry.
No, he can come near the mic. There's no problem.
Yeah, Gokul come.
Gokul, Shiva, both of you can come near the mic. So this is an AI generated image which shows 2 surgeons, 3 surgeons evaluating the spine, and we'll come back to it. So this patient interestingly presented to us. He's a 32-year-old gentleman who presented to us with complaints of neck pain, which was insidious in onset, gradually progressive. He had spastic quadriparesis for last 1 year and paresthesia. He also had bladder and bowel involvement. He had frequency, hesitancy, urgency, urge incontinence. So all these features were there. And he had spastic gait paresis. He had modified Ashworth grade 2 spasticity in all limbs. His power was 4/5. Deep tendon reflexes were exaggerated. He had inverted biceps. Pectoralis, scapulohumeral reflexes were normal. And below C5, there was around 20% sensory impairment. Single breath count was also done, and interestingly, it was 30. He could hold the breath for 30 seconds. And this was the imaging. So, what do you think, Gopal, this looks like to you? You see these cases every day of your practice. Now you are in Rohtak. I'm sure you must be seeing all these kind of cases. So there is a intramedullary change here at C3-4 level, and this is the kind of imaging which was there. Harshit and Gopal, anything you want to add to this? Can you pass the mic to them, Datta? Can you please pass the mic to them?
So what I feel is definitely there's cord edema, and it is most likely due to compression at C2-3 and C3-4 levels.
Very nice. So anybody else who wants to add? Can it be something else? So you think it's a disc disease?
Most probably.
Most probably. Roshan, you want to be different, or you want to add the same thing?
It can also be an intramedullary lesion, so we should get a contrast MRI of the patient.
Very good. So Roshan has said that we should get a contrast MRI done, and I think it was done. So this is the contrast MRI of the patient, which shows that there was enhancement of the cord at that level. Shiva, do you think it is what it is? Now there is enhancement of the cord here. Any differential you want to add, Hitesh?
Sir, before that, I would also like to have flexion extension images.
So I'll just show you that also, flexion extension imaging. And but why do you want to get a flexion extension imaging?
I'd also like to have a history of any trivial trauma.
Okay, so there was no history of trivial trauma in this patient. They didn't tell anything about the trauma at all. He had no history of trauma at that point of time.
Now, this contrast enhancement could also be because of edema, because edema can also have contrast enhancement.
Very nice.
And tumor can also have a contrast enhancement.
So your two differentials are tumor and heart signal change due to the disc disease, right? Shashwat, you probably know this case.
Is the contrast enhancement in the posterior columns?
Shashwat want to make it more confused. Don't worry.
Is the contrast enhancement in the posterior columns?
Yeah, it was more. I'll show you one more picture. That will make it very clear after that.
So I would like you to go back to the T2 sag.
Yeah.
Here in the T2 sag, we can see some kind of striations inside the
Yes.
T2 weighted imaging.
Yes.
So that would lean in favor of, not in favor of intramedullary pathology. Like this would be akin to somewhat like we see in diffuse midline gliomas, where we see that the tracts are involved, so tracts are inside the edema.
So Shashwat is very correct. This can be an intramedullary tumor also, right? which is intraaxial tumor. And this is what was diagnosed by somebody. And this patient came with this diagnosis of astrocytoma. And like it is done here, patients usually have a long duration of history of symptoms, and they're given usually a date for surgery, which is very long. I mean, sometimes 6 months to 1 year. So this patient was given date for surgery because this patient was diagnosed to be a case of astrocytoma.
Excuse me, sir. Can it be a case of demyelination?
So that is what I want to know from you guys. So now you have
What's the
come up
age
with
of-
the differential diagnosis.
So what's the age of this patient? Yes.
The age of the patient was 32 years. He was a young guy.
And can I have that contrast enhancement images again?
Yes, you can have contrast enhancement images.
I would like to put demyelination also, sir, because there is patchy enhancement. Okay, the
So
pattern of
one
enhancement-
differential very rightly put by him is this patient can have transverse myelitis. He can have demyelination. Not always think of neurosurgical pathology if patient lands up in your outpatient clinic. It can also be a pathology related to other disciplines about which you may not have clue. So this can be transverse myelitis, this can be demyelination, but there are ways to differentiate that. So now you have three differentials, big three differentials. One is tumor, another one is cervical PIVD, oblique trauma, which Hitesh said, and another one is something which is neurological, transverse myelitis or demyelination. Again, I come back to you, Hitesh. How will you proceed from here? You wanted this X-ray. So we got this X-ray done. So here is the X-ray for you. How will you proceed from here? This patient is there. Now it has been admitted to the ward. How would you like to go about it? You have three pathologies with you.
Yeah, you have 30 seconds to answer.
You can speak anything. We are not going to judge you.
Yeah, but quick.
So what about the flexion extension scans?
So this is the X-ray which we had, and this is the flexion extension X-ray. So we must get flexion extension X-ray done, and this is what Professor Kale is teaching, and the teaching here is that if a patient comes with this kind of a pathology where you suspect a degree of instability causing a problem, always get a flexion extension and a neutral X-ray done to look for instability, to look at the sagittal balance. So always get it done. So very nice, Hitesh. I think we should always make it a point, all residents, that whenever you go back, if you see such kind of a patient, always advise this. Harshit, you want to speak something?
We have a suspicion of tumor also, so why not get MRS spectroscopy?
So MR spectroscopy, if you do for spinal lesions, it is very difficult to do because to put voxel in a very small area is not an easy task. Amongst all MR techniques which are available, the perfusion, DTI and this spectroscopy, they are quite user dependent. So unless a person is very experienced, you won't be able to do it. The other thing, yes, you have rightly said, you can do DTI imaging to look at the tracts, what's happening to the tracts. But again, it's very difficult to do. You require software, this gadget, that gadget, which is not readily available.
Sir, also in the three months period, whether the symptoms were progressive or whether they were static?
The symptoms were static. He was what he was.
Was there any resolution? Say many a times.
There was no resolution in symptoms. He remained static.
Was a trial of a steroid tried?
Steroid trial we usually don't give to patients if we are suspecting intramedullary tumor. So this patient was suspected to have astrocytoma. We never usually give to spinal patients. We don't give usually unless it's a brain lesion which is causing lot of edema. In this kind of a situation, we sometimes give.
So did we repeat an MRI?
So that's a nice question. We repeated the MRI. So we repeated this MRI, and this is the picture which we got in the MRI, which shows the T1 weighted image, the T2 weighted image, which again shows nearly the similar amount of edema, correct expansion at the level, and again there is enhancement of contrast at the same level. And what Dr. Patkar wanted to see was the contrast image, which is here. You can see that the contrast is enhancing part is here, somewhere here.
So the value of vision is much more extensive than the contrast.
Yes.
The amount of contrast enhancement and the amount of expansion of the cord is disproportionate. So I would put tumor very down in the list in this case. It does not match. There is no concordance between the tumor. Second, the disc, if you want to blame the disc, this was, how much period has passed since this MRIs?
3 months.
3 months.
3 months between the two MRIs.
So definitely this is not myelomalacia. So even trauma is out. The tumor is out, trauma is out, you're left with demyelination.
So
Yeah, Professor
the
Rajendra sir.
Nothing much except like Hitesh said, he wants to rule out the possibility of minor trauma. See, in cases of whiplash injury, the classic teaching is there won't be any changes in MRI. But all patients, invariably all patients will have changes in T2 weighted image. And for all whiplash injuries, the severity of the trauma will be significant. So there's a good possibility of diagnosis, but maybe like, I don't think it's traumatic because that history will be anyway available. Most likely to be a case of ADM.
Sir is also right, because occasionally, unlike the Western countries, our patients have got huge tolerance. Minor trauma is occasionally missed by them. They don't even realize that there has been a minor trauma. They relate to something else. Or at times it can be the reverse of it. They may relate the whole pathology to trauma. Day before yesterday, there was a patient who was admitted. He was diagnosed as a case of Korsakoff psychosis by the neurology department. But I knew the diagnosis because he was known to me, but when he came to casualty, nobody was able to trace him because he was shunned to trauma center, because the moment he landed here, they said it was because of an injury which happened 1 year back, while it was because of abstinence from alcohol or maybe more of alcohol.
What is your opinion?
It's a very complicated case. I should have done the first step, brain MRI, to rule out multiple sclerosis should be also a plaque. But by looking with special attention at the T2 MRI, we see a bulging disc and an hypertrophy of posterior longitudinal ligament. If we draw a line to measure the diameter of the spinal canal, it is 2/3 compared to the normal. And that pushed me to think that hyperextension situation, a trauma, something like that, could injure the spinal cord. What I don't understand well is the so huge extension of hyperintensity in T2 of the spinal cord. And because just in case of a very simple trauma, I should expect a spot, not a far line. So I'm not completely sure.
Yeah. May I
So
ask?
what sir has said, it comes by way of experience. And with experience and gray hairs, everyone becomes wiser, I think. So this patient, sir, accidentally underwent the cranial MRI also, because this MRI was done here in the institute. So even if we at times prescribe spinal MRI and they are not able to diagnose the cause, they will do n number of MRIs here. That's the practice in the institute. So this patient underwent the cranial MRI also, incidentally. But having said this, we have discussed all the differentials which are here, trauma, tumor, transverse myelitis, everything. The report which was given to us was this, which showed an astrocytoma. This is what was reported by the radiologist here. So how many of you are going to straight away operate this patient? Can you raise your hand? Anybody who is going to operate this patient? Kamalji, you wanted to speak something.
Operate for? Considering
Astrocytoma. The report is astrocytoma.
If you can go back to the MRI.
Yeah, I can go back to MRI.
So we can see the behind the C4 body where there is contrast enhancement, the spinal cord is actually narrowed. So there is a
Yes.
So had it been a intramedullary tumor, we'll expect the spinal cord to widen.
So very correct. I mean, you are correct in your own sense, and everybody is correct here in their own sense.
And
Radiologist now has given the report of astrocytoma. This is the second report of astrocytoma for the same patient based on the MRI. How many of you are going to operate this patient? Nobody.
May I ask the question, like, have anybody operated astrocytoma and came out as a demyelination, or you operated?
yes, I
Yeah.
have done it. Yes,
It's-
from that experience, I learned that I will always repeat an MRI in suspicious cases, where there is no clear-cut indication that this might be an intramedullary tumor. I will get an interval MRI done after 1.5 months. Intramedullary tumors are not going to worsen terribly in 1.5 months.
Yeah.
So because they are mostly benign, long-standing, and the duration is in years.
Yes.
Symptoms are in years. So there is nothing wrong in waiting for.
CSF study done? CSF study was done?
No, we didn't do CSF study till this point. No CSF study was done till this point. Dr. Park, would you like to say something? Or you do?
Sorry, I am only degenerative. I am only focused on for all my life, focused on degenerative disease. So I am knowledgeable for intramedullary tube. Very short. Sorry for that.
Okay.
Thank you, Professor.
Yeah, Satish.
So to me, it appears like because there is a. Can we go back to the MRI?
Yes.
Second MRI. Yeah. So the disc space is quite the canal space is quite stenosed at C3-4 level from anterior as well as posterior, and the enhancement is also there only. And what I can notice is that the extent of cord expansion has reduced in the second MRI. So it may be probably because of degeneration only. We could have got a dynamic MRI to rule out any dynamic compression.
So dynamic MRI, yes, Satish has very rightly said.
So what we are saying as cord expansion may be the normal brachial enlargement of the cord in the cervical region.
So
And there is, as compared to the previous scan, there is regression actually of, and there is, the size has actually reduced. So
Yes, Harshit.
So can we go back to the MRI?
Everybody wants to go back to MRI.
As Kawaljeet said, that the C3-4 level, the disc appears to be bulging and impinging on the cord, and it appears more to be the epicenter of the signal changes, above and beyond. Means it's basically more in the center of the cord signal change. So that is most likely the causative lesion, I believe.
So you have narrowed it down to the disc disease.
Right.
Okay.
Why should
Yes,
the
sir.
contrast be in two separate enhancements? There is one enhancement in the front, one in the behind. This is not the kind of contrast that you see when there is compression, you know?
Sir, the pattern of enhancement, if we notice, it is a sort of patchy enhancement. And has it been an, say, astrocytoma? Usually it is a diffuse sort of. Patchy enhancement goes more in favor of demyelination.
Did you do-
So
did you-
I will
did-
strongly put diagnosis of demyelination in this case.
Did
and
you
would
do
like to
VP?
watch this patient over a period of time with the challenge of steroids.
Did you do VEP?
VEP, no, we didn't do VEP till this point of time because everybody said it's astrocytoma till this point of time. The radiologist opinion twice was astrocytoma, so no VEP was done till this point of time.
We can take a raise of
Yeah, sir wants to speak something.
Sometimes we can see this picture on the MRI when there is a spontaneous insult of the spinal cord without any trauma. Just a problem with thrombosis, for example.
Yeah, it can happen.
Yeah.
So
We have seen similar kind of pictures at craniovertebral junction where patient has got mobile AAD, and somehow somebody got contrast enhanced MRI done which shows enhancement of cord like this, exactly patchy, sort of inhomogeneous enhancement, but that was clearly secondary to the repeated compressions causing cord damage leading to enhancement, not because of the tumor. So here, if you look at C3-4, definitely there is a disc, definitely there is canal narrowing, and could be there is some subtle sort of motion causing cord.
So here is the flexion extension.
3-4, there is the on extension, hyperextension. At 3-4, there seems to be some hyperextension. You can see there is slight motion on the
Posterior listhesis, you mean? Somebody will again ask you to go on, right?
So now, I mean, the consensus appears that many of you who are saying that it's C3-4 disc, can you raise your hands? Satish,
Yeah, raise of hand, C3-4 disc.
And those who are saying it's transverse myelitis, can you raise your hands?
Transverse myelitis.
Transverse myelitis. Those who think it's astrocytoma, can you raise your hands?
So I mean, most of the people are waiting for you to tell us.
No. So point of the matter is, see, if you look at the common intellect in this whole group and the number of cases that people have operated, it must be at least 20,000, 30,000 cases people must have operated who are there in the room. But still at times, there is a patient which confuses you. And none of us can always be right. And I'll show you just right now. Because you look here, will you take the plunge when you ask this question to any person? I'm sure if I ask the same question, Satish, will you operate C3-4 PIBD for this patient?
I would just like to observe and get a follow-up MRI after 3 months.
Very good. So that's the most pragmatic answer, I think. When you are confused, I think you should wait.
This answer is true for all the three pathologies that you mentioned. For
No, if it's a
astrocytoma,
tumor, it's a tumor, patient can sue you. Why didn't you operate me? Patient can sue you that, why didn't you operate me? Now my tumor is bigger. So I think, but it's the most pragmatic answer to give, that I will wait, I'll do a repeat imaging. And But we must be aware, and sometimes knowledge makes us wiser, and we were not aware of this. But like Dr. Rajendra said, we were suspicious that no, this doesn't looks like tumor to me. So this patient was posted in my colleague's operation theater, but we have a system here that before we go to operation room, we have a discussion with the neuroradiology team. And we had this report which said, by them only, the report had said that it's an astrocytoma. And we showed this report to them that, see, you guys have only said this, is this astrocytoma? I'm not convinced. Then one of the senior radiologists said, no. Who said this is astrocytoma? This is not astrocytoma. This is C34 PIVD only. This is a disc disease. It is because of the compression that this is happening. And then he told us that there is something which is called a pancake-like gadolinium enhancement, where the enhancement in height is lesser, but in breadth it is higher. And it is very pathognomic for this kind of a disc disease. So he said that this is the hallmark, and I am betting my life that this is not astrocytoma, but this is this. And having said this, we must realize that occasionally these patients, they have venous hypertension, and it is this venous hypertension which leads to kind of erratic enhancement which is present in the cord. And we must all be aware of these few things. But having said this, we must also realize there are few other pathologies which can present like this. One is the paraneoplastic cancer. I mean, these can present like this, syndromes. But the pattern of enhancement is different. It is linear enhancement in here. Where here the enhancement is more like pancake, it's broader, not in height. And anterior spinal artery infarct, but anterior spinal artery infarct will have a patient who will have presentation which is very acute in onset. Transverse myelitis, even the presentation will be different. It will not be 1 year of stable presentation. Patient will continue to have few developing improvement. There will be deterioration, some kind of a step ladder pattern which we will be able to see. So there are reports I searched and I found this. Now this question is to you, Shiva. What do you think this is? This is for residents. So Gokul has run away, I think. He left.
No, he's just sagged up.
So what do you think, Shiva, this is? This is C34 PIVD or is it something else? Just anything, yes or no?
Yeah, quickly we have to
Very
move forward.
quickly. Just take the mic in your hand and just speak. What do you think it is?
You can say demyelination.
Very quickly. Do you think it is C34 PIVD? Yes? So this is listhesis, but this is not PIVD. This is transverse myelitis, and it is because of a bacterial infection in this patient. So always take the history of the patient. What do you think this is? Is this tumor? Is this disc? There is a disc also. What is this? 3 options. You can choose A, B, C. You can take a vague guess. This is transverse myelitis, tumor, this is disc. This looks like tumor to you, but this is not tumor. This is transverse myelitis, right? What is this? This is tumor, this is disc. You can choose anything out of 3.
Yeah, you can say OPLL.
You get a bonus mark for your exam if you choose correctly. Choose anything, and no negative mark for choosing. What is this? This looks like a tumor to you. This is not tumor. This is spondylolytic myelopathy again. And then, again last, what is this? This is tumor, this is disc, this is transverse myelitis. So you got it all wrong. So fact is that we will all get it wrong if we do just look at the radiological picture. Do ask the patient what is the problem he is suffering with, for how long he is suffering with it, whether he had very rightly put, whether he is improving, whether he is deteriorating. It gives you lot of cues, and that is where the importance lies. This patient which was in question, this patient underwent C34 ACDF which was done. He improved later on. And just coming to the last part, by God forsake, suppose we have operated this patient which was in question, and it turns out to be the usual, that is the normal tissue, or the pathologist will tell that the tissue was insufficient for diagnosis, and it turns out to be a disc disease, and now patient is paraplegic. What is going to happen?
Do you want real answer or some?
I want real answer, because this is in today's circumstances. I think in the country we are walking the western path, where in case you make a mistake, the patients are going to be after our life.
Yeah, so if you have
So,
operated,
Dattaraj, to you only, you only answer this.
Yeah, I
Will,
mean,
will
see-
the blame lie squarely on the radiologist who had written the report and signed the report that it's an astrocytoma, though they had written very blatantly, clinically correlate this, blah, blah, or the blame will lie on the surgeon?
I mean, when you are taking a call in best of your knowledge, yet your experience, I mean, you can take an opinion, you have taken opinion of radiologist. That may be the only person available. Not like AIIMS, you have n number of people and n number of time you are discussing it. Like my colleagues take opinion from us, like they send us images on WhatsApp, and it's like taking opinion. You are taking best opinion and moving forward in best of your knowledge. You can justify.
Manoj, do you want to say something? Who is responsible, the radiologist or the surgeon?
Nobody, you have to explain it.
No, the surgeon is responsible.
So Manoj is absolutely correct.
You should think before you put your knife to a patient.
The thing is, that is a very,
the person who puts the knife will get the blame. That is what the law is, not only in India, but unfortunately abroad also. So the person who is putting the knife, he is going to get the blame. Satish, you want to add something, I think.
We should read the report carefully. The radiologist had written likely astrocytoma. They haven't.
Nothing matters, even if they report wrongly.
Yeah. So exactly,
Still,
the blame has to be on the surgeon.
the blame will lie with the surgeon, the person who has put the knife. So
Yeah.
be very careful about it.
Yeah, that is a very practical point, but what would have happened? You would have taken the tumor out, tumor is insufficient for diagnosis, there is already cord myelomalacia, in post-op case, there will be good space around the cord.
And patient will be paraplegic or
Patient,
quadriplegic.
yeah, I mean, you are saving yourself now.
So I think the bottom line of presentation for this kind of a case was to present a simple case which can have a diagnostic dilemma, and to re-emphasize the fact that all of us at times should very carefully examine the patient clinically
Yeah.
before taking a call. And whenever you have a doubt, take opinion from a senior colleague, or just wait and watch, repeat the imaging after some time, again do it in case you have confusion.
Yeah.
Thank you.
Thank you. Where is the Rohit Kavishwar? Yeah, please go ahead with the present.
Before
Please.
I go out, I think, Datta, you must have informed them. We have a Diamond Jubilee celebration. So all our alumni are informed. If anybody wants to register, they can
Yeah,
register.
we already
at
given
the
them
counter.
5% concessions. 100%? Okay. No, not for alumni, I mean.